Good evening, all. I'm Dr. Anna Jo. I am the first year PG resident in MOC Medical College. Thank you for this opportunity. Let me begin with the details of the case. History. A 19-year-old male, a migrant laborer working as a gardener with no known comorbidities, presented to our emergency department with the history of fever, abdominal pain, severe myalgia, and headache of 3 days duration. Patient also had diffuse abdominal pain. He noticed yellowish discoloration of the sclera and skin for the past 3 days. On the day of presentation, he also had 2 episodes of vomiting. There was no history of decreased urine output, breathlessness, any history of blood transfusion, recent surgery. He was not addicted to smoking or alcohol. At the time of arrival to our casualty, his BP was 78/38 mmHg. Therefore, he was started on NORAD support. His pulse rate was 110 beats per minute. His respiratory rate was 18 breaths per minute. His oxygen saturation was 98% in room air. Temperature was 99.9 degree Fahrenheit. Icterus was present. The systemic examination was normal. A screening echo, which was done from our ER, revealed mild LV dysfunction, hypokinesia, and IVC, which was less than 2 centimeter and collapsing. After the systemic and general physical examination, our provisional diagnosis was leptospirosis. The differential diagnoses include dengue, acute viral hepatitis, rickettsial fever, and cholestasis. The lab values, initially the laboratory investigations revealed a total leukocyte count of 10,200. The platelet count was only 50,000. The total bilirubin was 28.3. The liver function tests were markedly deranged with bilirubin levels significantly elevated out of proportion to the liver enzymes. The patient was started with injection crystalline penicillin and injection ciprofloxacin owing to a clinical suspicion of leptospirosis on the first day of admission itself. And in the subsequent days, the patient's liver function test, renal function test, and platelet count and total count was monitored. Though the platelet count started to improve, the renal functions worsened initially, which later improved. Confirmation of the diagnosis of leptospirosis was made by TrueNAT leptospirosis, where the leptospira DNA was detected, and also by lepto-IgM, which returned positive results. Other infectious diseases were excluded. Dengue was excluded by using rapid tests for dengue NS1 antigen and IgM. Hepatitis, the markers for hepatitis like hepatitis B surface antigen, anti-HCV, HEV IgM, and anti-HAV IgM were non-reactive. Other infectious screening done included COVID antigen test, HIV test, then the Wheel Felix test, which all came out to be negative. But even with the improvement in all other parameters, the bilirubin levels showed a rising trend. On day 4, from initiation of the antibiotics, the total bilirubin count was bilirubin level was 40.1 milligram per deciliter, and direct bilirubin level was 37.5 milligram per deciliter, and the urine color was near cola. At this juncture, we did a USG abdomen and MRCP to rule out any obstructive causes of jaundice. Among other tests that we did, it was the ECG and peripheral blood smear, which were normal. When radiological investigations revealed no obstruction, suspicion arose towards any drug-induced causes for hyperbilirubinemia, following which crystalline penicillin and ciprofloxacin were discontinued on day 7 and day 6 after the initiation of treatment and admission respectively. In the subsequent days, there was a rapid fall in the bilirubin level, which was 4.2 milligram deciliter on day 11, and there was also corresponding clearing of urine. At the time of discharge, the total bilirubin was 3.5 milligram per deciliter. This was a progression of jaundice. On 11th of February, This was the color of the urine, and progressively the urine became clear. The dramatic improvement following medication changes strongly supported drug-induced hyperbilirubinemia as the cause, with complete resolution coming within 1 week of intervention. Final diagnosis, leptospirosis with multi-organ dysfunction syndrome, which included acute kidney injury, hepatitis, and thrombocytopenia, probably drug-induced hyperbilirubinemia. Review of literature. Leptospirosis is a zoonotic disease caused by pathogenic Leptospira species with clinical manifestations varying from mild forms with non-specific symptoms like fever, headache, myalgia, with severe leptospirosis called as Wheel syndrome, which includes jaundice, renal failure, and also hemorrhagic diathesis. It has a worldwide distribution, but most commonly occurs in tropics and subtropics because of the climatic conditions and the poor hygienic conditions in these areas. Rodents, especially rats, they're the most important reservoirs, and transmission of leptospirosis may follow direct contact with the urine, blood, tissue from an infected animal. Diagnosis mainly based on the clinical diagnosis based on the exposure history and the clinical manifestations. And the definitive diagnosis is by microbiologic and molecular tests, where PCR, which is the best test in the first 5 days, which detects the leptospiral DNA, which has high sensitivity. Serological tests include the microscopic agglutination test, which is the gold standard test. ELISA is also there, which detects antibodies, but antibodies appear after 1 week of therapy, and it can be blunted by early antibiotic therapy. Rapid tests includes lateral flow, latest agglutination, rapid ELISA, which are used in resource-limited settings. The treatment, mild leptospirosis, is treated with doxycycline or amoxicillin or ampicillin. Severe leptospirosis can be treated with penicillin, ceftriaxone, cefotaxime, and doxycycline. Chemoprophylaxis using doxycycline and azithromycin. Based on a similar case in 2022, a case report was published by our HOD, Dr. Abraham Atiachan sir and his team. It was published in the SN Comprehensive Clinical Medicine, a PubMed index journal published by Springer Nature, where a 23-year-old male who presented with fever, myalgia, and jaundice, diagnosed to have leptospirosis. He was started on ceftriaxone. Despite clinical improvement, the bilirubin levels kept rising, peaking at 45.4 milligram per deciliter on day 4. Suspecting a ceftriaxone-induced cholestasis, the antibiotic was discontinued. After stopping ceftriaxone, the patient's bilirubin levels, it came down, rapidly declined. During that time, this was the images of the urine color corresponding to the total bilirubin level. When it was 45.9, it was clear cola color, near cola colored urine, and there was subsequent clearing of the urine. During that time, a literature review was done to find out the causes of hyperbilirubinemia, which was included in the study. The direct causes included damage to hepatocytes, which leading to the leak of bile into the sinusoidal blood vessels. Indirect causes included hemolytic anemia, G6PD deficiency, Jarvis-Hexemer reaction, drug-induced hyperbilirubinemia. Take-home message: hyperbilirubinemia and leptospirosis has multiple causes, and if the bilirubin fails to come down, it's always keep in mind a drug-induced causes of hyperbilirubinemia. And it's also important to recognize drug-induced liver dysfunction in tropical infections. Thank you.
So, like I told you, we had a couple of cases like this. This was the latest one which she presented. The other one was in 2022, which was published. So, actually, when that case came only, when I did a literature review, I found that it was not described anywhere in literature. Probably it's because it's from a tropical country. And regarding the causes for hyperbilirubinemia in such a case, it's not given in any textbook, or all the points together are not given in any journal. There are some reports individually from different journals, so which we actually collected and included in the discussion of that article. So especially for PG students and all, if someone asks what are the causes for hyperbilirubinemia in leptospirosis, there are actually multiple causes. It's not just one or two causes, and it's not described in any standard textbook. The this case is open for discussion if you have any questions.
Thank you for the nice presentation. Couple of points to clarify. G6PD levels were done.
No,
sir.
none of
No,
those
sir.
was done because after stopping the drug, ceftriaxone it came down. So we presume it's due to that. Now those were not done.
The bilirubin value in February was 3.5 on discharge.
Yes, sir.
Any other follow-up values are there?
No, sir. The patient went back to Assam.
Yeah,
after
naturally.
that.
He's from northeast. So he
I thought so, because we would like to repeat the bilirubin even after you discharge, because you discharged him on 3.5, which is of course not normal. The other question, malarial parasite, you would have done definitely.
Yes, sir.
It
is not
It is
seen.
being done. Now, the other thing is pre-existing congenital hyperbilirubinemia, we don't know, worsening with this infection. The classical teaching says a fever with jaundice is not viral. In viral hepatitis, fever is a prodrome. Fever disappears and the yellow color comes. In bacterial and protozoal, like malaria and amoebiasis, and bacterial like salmonella, leptospirosis, fever coexists with jaundice. So here, what was the temperature on admission?
Temperature was 99.9, sir.
Hardly. Okay, that is bottleneck. So fever with jaundice points towards non-viral hepatitis causes. That's one point usually we use to differentiate.
Okay.
And to extend your imagination, maybe you can get the LFT of the relatives done, but in this case, the patient himself is not available after discharge. So otherwise, some familial conditions to rule out. Are you planning, if at all this patient comes back, if at all, are you planning for a liver biopsy if the bilirubin still remains high?
Very unlikely he'll come with a migraine labor.
Okay, that was just a theory. I know they don't come back.
The first one, actually, the one which we published, he came for review. It was normal. That was actually a Malayali only. The second one was a migraine labor. The one she presented.
They may come back to blame you.
45.
Very high. 45.
Very high. No, but leptospira, you never see so much high bilirubin.
So it should, there may be some amount of icterus and hemorrhage, and the immediate differential diagnosis was a hantavirus at that time.
Yeah. Here it was very classical. We stopped the antibiotic next day. Ceftriaxone is known to produce cholestasis, but not in all people. That's what when we suspected. It was all the other parameters started improving. His renal functions improved, platelets started improving. Only thing is that bilirubin and the bystanders were more concerned. Actually, if I remember right, he was, I think, 22 years old. The father was more concerned about why the jaundice is not coming down.
He didn't develop that mortality despite the bilirubin of 45 in a patient.
Yeah, but in adults usually it doesn't produce morbidity or mortality. Morbidity, if at all it interferes with your lab tests. The high bilirubin level can interfere with so many lab tests.
Question is, in leptospirosis, why you started ciprofloxacin?
That case, I think she didn't tell, because when the patient came with a case like that, low BP and all, we never take a risk. We actually start a broad spectrum antibiotic to cover for gram-negative infections. That is, whether there is an underlying sepsis or a sepsis together, we never take, because CP, crystalline penicillin, is actually a very poor antibiotic as far as other infections are concerned. It will cover only lepto. So no one will take that risk of starting CPLO. That's the only reason.
In leptospirosis, anectric hepatitis is an entity, and in Harrison it mentions cholestatic phase of phase can occur in leptospirosis.
Yeah, but
where
that is
the
more common with,
alkaline phosphatase will be
yeah, it can go,
elevated.
but
In
that
this
is more
patient,
common
alkaline
with,
phosphatase was high.
No, sir. It
no,
was
it was
not
not
high.
very high. I don't
It was
remember the
not very
exact
high.
value. It's there. No? No,
We
it was
see
not very
so
high.
many patients with high bilirubin, like 28, 30, where the alkaline phosphatase will be very high in that patients. Thank you.